this year it was a fantastic session because we collected the great speakers about these topics. So one of the important topic was looking at the new possibilities on gene expression profile and moderating how we can make a more detailed prognosis of the patients with melanoma and how we can eliminate so patients forego sentinel biopsy because still it's invasive procedure and we try to find the best biomarkers which can show the prognosis of patients without extensive surgery. So this was the first important topic which we covered. Still, we are not perfect. However, it is one of the first steps how to limit the next step, how to limit the extent of the surgery in this field. The next topic was generally related to uveal melanoma. Uveal melanoma is also a fascinating area because for years we haven't anything to propose our patients except some local therapy when patient metastasize. Now we have a great local control, but still in metastatic setting, the prognosis is poor. However, recent discoveries showed that we have some steps ahead because we introduced Tebentafusp, which is one of the drugs related to connection between T cells and tumor cells to destroy the tumor cells with specific HLA status. And Tebentafusp was the first drug who showed the overall survival benefit in this difficult disease. Now we have new trials with targeted therapies, which are targeting PKC and MET, and combination of this drug is also very promising independently of the HLA status. Moreover, now EORTC also introduced the trial about adjuvant therapy in high-risk primary ocular melanoma using Tebentafusp. But this is not the only possibilities. It's also interesting liver perfusion, which can be utilized, and some centers introduced this with some success, showing some overall survival benefit and also local control benefit. And maybe the combination with immunotherapy of this local treatment can be a next fascinating area. So it was discussed by Dr. Kaptein, but also another day by Dr. Zagar. So this is what we had as a new things. However, I also presented in another session, I think that it's interesting, the topic about limitation, the extent of the surgical approach to melanoma. Because first, 20, 25 years ago, we eliminated elective lymph node dissection, introducing sentinel lymph node biopsy. Sentinel biopsy since 2009 is a standard of care as a staging procedure. But for years, we also performed completion lymph node dissection. When sentinel lymph node biopsy was positive, we went to the surgery, extensive lymph node dissection. Now we know that it's no difference in melanoma-specific survival if we perform completion lymph node dissection or not. So the next step, as I mentioned, probably will be changing the role of sentinel biopsy to only specific individual cases. And the next step ahead is also thinking about how to eliminate therapeutic lymph node dissection. Therapeutic lymph node dissection we perform when we have clinically detected lymph node metastasis in melanoma. But now when we introduced neoadjuvant therapy, and in many countries now it's reimbursed, NADINA or SWOG style neoadjuvant therapy, so preoperatively given 2 or 3 cycles of immunotherapy. It means that according to PRADO trial results, maybe in the nearest future we can only remove the index lymph node after neoadjuvant immunotherapy. And if this index lymph node shows that it's pathological complete response, it may be not necessary to perform therapeutic lymph node dissection. Now the first patient was introduced to MSLT3 trial. It is led by Professor Vanna Coy from Australia. And this is the trial directed to answer this question, should we perform any further extensive procedures after neoadjuvant therapy if the patient in the index node have a pathological complete response. So there are several fields. We are on European Society of Surgical Oncology meeting. So the surgical approach for melanoma nowadays is really changing and very fastly, but we are in the huge field of uncertainty, and new developments, especially in perioperative treatment, does not directly show what we should do now, but we still should follow the guidelines.